Okay, I have some question. I have some question by the audience, and I will first of all reply to this short question. Then we will start our second session. Okay, the first question is why do we need to extract the first premolar buds, enucleation of the premolars, simultaneously with the extraction of the deciduous first molar is serial extraction treatment? So why the enucleation instead of the serial extraction of the premolar? Yeah, thank you. This is an important point. I advise you to consider the enucleation a good option only in the lower arch, when the premolar are quite superficial, and it is very useful if you can extract the premolar the sooner you can. So this is the reason for the enucleation, in order to prevent a not parallelism of the roots. If you do an enucleation, it is more likely that the second premolar and the canine will have the roots more parallel at the end of the transition. This is the answer. So the second question is from the interpreter. I did a mistake before when I was talking about slicing, and I told you that I slice quite often the upper canine, deciduous canines. This is a mistake. What I usually slice are the lower primary canines and the second primary molars. These are the only three teeth which I slice quite often. Then I have another question. What is the mechanism of the spontaneous correction of the crossbite between incisors and buccal displacement of the incisor? So if we don't apply any spring or other device to these teeth, how can they expand? This is a topic I will go in the next lecture, and but a fast answer is that when you expand orthopedically, in the first 3-4 weeks, and here you see it very well, you have an opening of the bite, because the molar palatal cusp of the deciduous and also the permanent teeth, so the palatal cusp of the permanent and deciduous second molar are touching on the buccal cusp of the lower molars, and so you will notice an opening of the bite, which is enough to allow the crossbite self-correct spontaneously. Spontaneously self-correction means 87–90% of the patient. So in very rare cases, I have to add maybe an elastic, but usually the open bite you get in this stage of the treatment, in the first month, let's say, is enough. I will go into this topic again now. Okay, these were the three questions I had, and I try to give you an answer. So now we will go in the second topic of my presentation, which is expansion, indication and method for the expansion. I will talk about these three kind of appliances, these three different types of the same appliance. On the left, you see the Haas appliance with the acrylic on the palette. This is what I use in 85% of my patients. In the middle, there is a Hyrax without resin. And in the right, we are using a lot of TADS supported rapid palatal expander in the last 10 years. And they work very well. So we will talk about these three kinds of appliances. To do what? These are the indications to fix a posterior, bilateral, left and right posterior crossbite. The second indication is fixing the anterior crossbite. Sorry, there is a mistake. Anterior crossbite, not AP, but AXB. And then I use this kind of expansion in the absence of the posterior crossbite just to fix the anterior crowding. Of course, but this is a topic of the afternoon, I use the same appliance to fix the unilateral posterior crossbite, which is very often to be noticed. So the posterior crossbite can be bilateral, the left and the right, or unilateral. In the afternoon, we will talk about asymmetry and unilateral posterior crossbite. Now, in the next 8 minutes, I will talk about how to fix by expansion a bilateral posterior crossbite, an anterior crossbite, and why to use these appliances in the absence of posterior crossbite, just to fix the crowding. A brief introduction. You know there are two kinds of expansion: Haas appliance with acrylic in the palette, and Hyrax, the Hyrax screw, which is only stainless steel with no acrylic in the palette. I'm not interested in using this kind of appliance with the bands on the permanent molars. I think this is very wrong nowadays. There are very, very limited indication. I prefer to use always, also in the presence of posterior crossbite, this appliance. So mixed dentition after the eruption of the permanent molars and rapid palatal expansion bonded on the deciduous canine, banded on the second primary molars. Why? Why this kind of procedure allows me to do a lot of prevention, and it is much more effective. It works much better. I can do much more things in a better way. What about prevention? You know that when you expand the palate in a traditional way, you will open the suture in a V-shape, opening of the suture. How much force are you using? When you use it after 10 years of age, usually the force is around 8 kilos, 16 pounds during the active expansion. In the young kids, I never measured the force, but in the first stage of the mixed dentition, when we use the appliance I'm talking about, for sure we are using not 8 kilograms, but probably only 2-3 kilograms, because the suture is not yet structured. Very easy to be opened. What do we have to prevent? It is evident in the literature that when you expand with such kind of forces, 8 to 10 kilograms, the roots of the anchor teeth will resorb. This is the root resorption of the anchor teeth which was observed from 1971 to 1994 in all the anchorage teeth. I don't want to create any resorption of the roots of the permanent molars and of the premolars, so prevention. Then I want to prevent the main side effect, the main negative side effect of the expansion using the permanent teeth as an anchorage, which is tipping of the permanent teeth, of the anchor teeth. When we expand the maxilla, we also tip the premolars and the molars. We move the teeth out of the periodontal envelope. And tipping is not a good movement. I want to prevent the tipping. So I think it's very wrong to use the permanent teeth, which must be moved in a totally different way to support the rapid palatal expansion. And then, of course, you also create an open bite. If we use the appliance, I prefer to use bounded on the second deciduous molar. You can grind the second deciduous molar, which must stay overcorrected for 1 year and control much better the open bite. We know that this tipping is very much, especially if we use the Hyrex appliance. Tipping is 40% of the expansion, 50% of the expansion. So tipping is too much and always a wrong movement. And this is the reason why I recommend you never to use, if you can, the permanent teeth as an anchorage. Then we know that when we expand the palate, we create an opening of the suture. This is orthopedics, much more if you use a Haas appliance, a little bit less if you use a Hyrex appliance. But this tipping on the molars, which means moving the teeth out of the periodontal envelope, is something which can produce the risk of creating recessions, periodontal problems. Not only because we tip the teeth, but because the basal bone comes back. When we expand the palate, we tip the teeth, of course. We expand the bones and we tip the teeth again, but then the bones comes back. So during the retention phase, during this very slow phase during which the bone is coming back, the basal bone is coming back, you have to imagine the alveolar bone which is pulled out of the roots. And so there is a major risk of periodontal damage also in the retention phase. This is the reason why Haas decided to use the acrylics in order to prevent the relapse, the major part of the relapse of the basal bone, which comes back in the year after the active expansion. And we know from the literature that there are, with a high by individual variation, there is a significant risk, not high, but a significant risk to create a periodontal breakdown. It has attachment loss, recession if you are unlucky. Even more if you use a Haas appliance. The Haas appliance is related much more than the Hyrex appliance to a reduction of the buccal alveolar bony crest. In other words, risk of periodontal damage. We don't want to see the root out of the cortical bone. Maybe you don't have a recession, but this is not what you want to do on your son, on your daughter, on your patient. So please, if you can, never use the permanent teeth as an anchorage. Always talking about prevention is not using a rapid palatal expander in primary dentition. that you will be able to achieve the best. It's too early. We will be talking about timing. This is not the right timing. We want to use it in mixed dentition, after or during the eruption of the lateral incisors and during or immediately after the eruption of the permanent molars. The second reason to use this kind of appliance is that it is much more effective. Much more effective means it works better. It works much better. If you use this kind of screw, it is a 13 millimeter screw, always a 13 millimeter screw. Maybe I don't need 13 millimeters, but if I need it, I want to have it. So always 13, 12 millimeter screw, not less than 10 millimeters. Less than 10 millimeters means having a lot of problems. Sometimes it's not enough. So 12, 13, better, not less than 11 millimeters. Why it is more effective? Of course, we expand the suture. We know this is very important. The mid-palatal suture opening allows us to achieve a better orthopedic effect. And I always expand orthopedically in the first 2 weeks because I want to start with an orthopedic extraction of the suture, always. Also in the cases when the palate is not so narrow. So I start 1 or 2 activations a day until the diastema is evident. Maybe not so big, maybe a little bit less, but I want to be sure that I opened the mid-palatal suture. Once again, even more, if I want to obtain an orthopedic effect, the acrylic is very important. And if I want to achieve an orthopedic effect, usually I go on screwing also twice a day beyond the second week. We will talk about the protocol along the lecture. The most important reason why you have to understand this kind of appliance is more effective is that we can move the permanent teeth independently to the basal bone. In other words, we move the bone in this direction because we want to achieve an orthopedic expansion and we want to achieve space. But in many patients, and this is one of that patients, you observe a dentoalveolar compensation, a buccal tip of the upper permanent teeth before treatment, before the expansion. So in this patient, I want to expand the palate in this way, from here to here, but I want to move the permanent teeth in the opposite way. I want to move the permanent teeth like this. Of course, if you have the bands on the permanent teeth, it is impossible. But the reason why I want to move the teeth in this way is that I will get a better occlusion at the end of my treatment. So you must learn to, with an appliance, will expand the maxilla, expand the palate without touching the permanent teeth, which must be moved in a totally different direction. Now we can, provided that you don't place any kind of band and expansion movement, expansion force on the permanent teeth. This is what happened. The palate opens and the molars which were tipped before treatment now are very straight, very parallel each other inside the alveolar bone. We can do a better movement. The bone in one direction, the teeth in the other direction. The teeth are buccally tipped before treatment. We can move the palate in one way, the teeth in another way, and also improve the alignment and the occlusion, curve of Wilson, of the permanent molars. This happens, of course, in the non-crossbite cases. We can do it. These are the appliances I use, never touch the permanent molars. Okay, there are some key questions. Can primary teeth support the load? Are they too weak to support the load? And the second question is, okay, I understand that the molar and the incisor can be moved independently to the screw, but how can I manage the movement of the permanent teeth? Okay, let's start from the first question. Can primary teeth support the load? Last year, we published this beautiful article which allows you to understand if the second molars are good enough to support the expansion forces. And there is this APC line, which is a line which passes in the middle of the pulp of the permanent molars. And if this yellow line, which parts in the middle of the pulp chamber of the permanent molars, let you see that the cusp of the premolar is above it, it means that the deciduous second molar roots are good enough to support the expansion. If the cusp of the premolar is below this line, could be that the deciduous molar roots cannot support the load. This is the APC line, half pulp chamber line. If the cusp of the premolar is above, is good. Actually, I don't check only the second primary molars. What I do, I check very carefully also the length of the roots of the primary canines. I want to see the primary canines with more than a half of the root length available. And at this point, I'm sure that I will never have a problem during the expansion. And the second key question is, what is the effect of the permanent teeth? How can we manage the posterior crossbite, the anterior crossbite of permanent teeth without touching them? It's not so easy in some cases. And I will show you many cases during the day. Let's start from the permanent molars. They expand together with the screw 60% during the active phase of treatment. Then they adjust in the ear after the active expansion because of the occlusal forces and because of the position of the lower jaw. The contacts between the permanent molars, of course, depends also about the correct position of the lower jaw. We want to have a symmetrical position of the lower jaw, which will affect the contacts on the permanent molars. So, first of all, we observe what happens. And believe me, if you start with a crossbite case and you start the expansion twice a day, 2 activations a day, for 1 week, then you check the patient, and if the crossbite is not self-corrected, another week, 2 activations a day, usually after 2 weeks, which means, of course, considering 2 activations a day, means around 30 activation, usually the posterior crossbite starts jumping or is already corrected. When you expand, You start from a fixed occlusion, at the beginning of the treatment, before treatment. After a couple of weeks, screwing twice a day, you have an open bite. Open bite means, once again, the palatal cusp of the upper molars are touching the buccal cusp of the lower molars. The bite opens. These contacts can be not ideal because they produce a shift of the mandible. Wait the end of the expansion before do a selective grinding. You need this opening of the bite to jump the bite, to fix the cross bite, both the posterior cross bite and the anterior cross bite. So when you are at the maximum open bite, palatal cusp of the upper molars against the buccal cusp of the lower molar, this is the days, the weeks when you have to notice the self-correction of the cross bite. If the cross bite doesn't self-correct in the first 6-8 maximum weeks, you must think that you have to do something else. Use an elastic, use a sectional wire, something. But in my practice, crossbite self-corrects in 90% of the patient. 2 activation a day is the way I start treatment in the presence of a posterior or anterior crossbite. And I check the patient every 15, 12 activations, which means if he activates twice a day, every week. We can also do a check at home using WhatsApp, using Zoom, using FaceTime, but it's better to see the patient in the office. The overcorrection on the primary molars, the scissor bite on the primary molars is the goal of the expansion. A scissor bite on the pair of the deciduous molars. At the end of the expansion, at the end, the day when I lock the screw, when I stop activating the screw, this is the day when I start grinding the palatal cusp of the deciduous molars in order to allow the permanent molars be in a stronger occlusion. And of course, sometimes you grind a little bit more in one side than in the other side. This is normal. After the grinding, only the permanent molars touch, and at this point, maybe the mandibular position is not ideal. Wait a few weeks before going on and doing something else. So you grind and you wait another few weeks, let's say 1 month, in order to see the permanent molars going down and touching in a better occlusion. This happens in the weeks after the locking of the screw. Usually takes 2-3 months. So I check after if the midline is correct, after the lock of the screw. Usually I use a stainless steel wire in the hole of the activation key. I check the patient every 3 months. And during time, the permanent molars settle down much better. The ground deciduous teeth allow the permanent molars to touch in occlusion much better. And the open bite fixes itself. Maybe takes 3, 6, 9 months, but it fixes. Now the screw is locked, and I keep the screw in the palate as a retainer, minimum 1 year. After the removal of the screw, if you are lucky, sometime treatment is finished. Everything comes spontaneously well. I want to show you, just to see all the steps. This nice girl, she started treatment. These are the dates. March 31st, 2021. So this was March, 1 month before, 1 month ago. Here you see the crossbite. This is the software I use in my office to see the patient, to write the charts instead of the charts. This is the starting, you see, crossbite, only on the permanent molars, March 31. This is after I started treatment. I didn't start treatment March 31 because these are the pre-treatment records. You want to know when I started the treatment in this patient? I started the treatment in this patient on May the 6th. And she started screwing twice a day for 1 week, 4 weeks ago. These are the picture after 1 week. This is 13th of May. She started on May the 6th. After 1 week, she changed from here to here. 1 week. You see the bite is starting to opening. Another week. Now the bite is open. It took 2 weeks, 2 activation a day. Sometimes the mother did only 1 activation because there was a little bit of discomfort, but after 2 weeks I have an open bite and the molar is jumped. So this is after 1 week, this is the beginning. After 15, maybe 14 activations, the bite starts opening. Now the bite is open. You see the crossbite is already fixed after 2 weeks. This is May 19, 2 weeks after the beginning of the expansion. This is May 26, but from 19 to 26, I asked the mother to activate only once a day. After that the crossbite is corrected, I asked the mother to slow down the activation rhythm only once a day. I don't grind the screw because I want an open bite. And here is after 1 week, 8 activations, only once a day. And here is now. This was yesterday. Treatment is finished. Now I wait. Midline is corrected. I locked the screw yesterday like this. I don't need more than this. This is a 13 screw. I don't need more than this now. For the molars, for sure, I don't need anything more. But for the incisors, I need more space. So yesterday, instead of saying to the mother, okay, this is enough, I said to the mother, go on, maybe now you screw once, you activate once every second day. The posterior crossbite is not a problem anymore. It is well corrected. But now, to gain space for the incisor, to prevent a tip of the central incisor during the closure of the diastema, she will screw only once a day. And I will check in the next weeks the midline. I want the mandible stay in this position. This is an example. And why I'm showing you this case? Because it's the last one I treated yesterday. It works very, very well. So this is the protocol. If you have a posterior crossbite, start twice a day. This is another example. Posterior crossbite, bilateral, class 2 malocclusion. Bilateral crossbite on the permanent molars. Of course, you can guess we will have crowding on the lateral incisor in the upper jaw. Very easy to guess. Narrow palate, bilateral posterior crossbite. MIH on the lower right permanent molar. COCR discrepancy. There are some prematurity and mandibular shift. Crowding, a lot of crowding in the upper jaw, much less in the lower jaw. The upper left canine, perhaps, maybe, is ectopic, but the kids, of course, moved when we took the panoramic, and so maybe it's not an ectopic canine. There are no missing teeth. Mild skeletal asymmetry, and a slight and very light skeletal discrepancy. For sure, it will grow and fix the skeletal class 2 just by growing. This is the expansion, full expansion, 13 millimeters. It took the whole expansion, 13 millimeters in this patient, to gain adequate space to fix the anterior crowding. Maybe I could have fixed the crossbite with less amount of expansion, but I need a lot of expansion to fix the crowding of the lateral incisor. So 13 millimeters using the protocol I've told you before. We start twice a day until the crossbite is self-correct, then we slow down to once a day or to once every second day if the problem is only the space of the lateral incisor. This is the arch form before the expansion. This is the arch form during the retention phase. You see very well that the molars, the permanent molars, are not following the deciduous teeth. So I have a scissor bite on the deciduous teeth, a squared upper arch. I need the screw acting also on the deciduous canines, because if you leave the deciduous canine free, if the primary canines are not bonded on the screw, they will not remain expanded. And if they don't remain expanded, they relapse, and if they relapse, the lateral incisor have no space. So we need four. I prefer to have 4 point of anchorage, and I need the anchorage on the deciduous canine in order to keep the space for the lateral incisor. What about the crossbite? Our topic now is the posterior crossbite. After 2 weeks, this is the crossbite is starting jumping. I already ground the palatal cusp of the upper the primary molars, because the crossbite is already corrected after 55 activations. This is the settling of the occlusion, the improvement of the occlusion also sagittally on the permanent teeth. The permanent teeth are free, they are trying to adjust themselves spontaneously after 1 week. After a few months. Here we are in the retention phase. It means July 2019, December 2019. So immediately after the correction of the crossbite, you lock the screw, grind the occlusal surface of the primary molars, and you wait, in this case, 3 and other 6 months. The permanent molars are moving, pushed only by the occlusal forces. And here you see the improvement. The improvement is huge, not only transversally, but also sagittally. It seems that there is no more the class 2. In fact, it is a much improvement, a great improvement of the sagittal occlusion. This is what I mean effectiveness. You will never be able to achieve this kind of occlusion on the permanent molars if you bond the permanent molars into the palatal expander. They want to not only to extrude and intrude, but they also rotate. They tip buccally and palatally. They adjust themselves in a very precise way. Look at this patient. What do you see? I see a crossbite on the right, the crossbite on the permanent molar. I see a mild crowding on the upper lateral incisors. I see that the reason why the crossbite is evident on the left, on the right, the reason why there is a crossbite on the permanent molars on the right is not only the upper jaw. The upper arch is not so narrow. There is a little bit of crowding. There is the crossbite. But the main reason why there is a crossbite is the lower molar, the lower left permanent, the lower right permanent molar is buccally rotated. So she has a narrow palate, not so narrow. She has a crowding of the lateral incisor, so she needs an expansion. But the reason of the crossbite is the lower right permanent molar. What I did, the same, in order to fix everything. Palate, crowding of the lateral incisor, and crossbite on the right, unilateral crossbite. I expanded the palate. And here is the expansion, not 13 millimeters, but for sure at least 35, 40 activation. Now you see the opening of the bite phase. She is touching only on the cusp of the deciduous molars. The upper right deciduous molar is touching with its palatal cusp on the buccal cusp of the lower deciduous molar. The permanent molars followed, and we know that they followed the screw 60%. And they also are starting touching. But I want an open bite during the self-correction of the crossbite. And the open bite can be provided only by the scissor bite on the posterior teeth. Now you see that in the months, 6 months after, in the retention phase, the permanent molars are coming back, are relapsing, are adjusting in a better occlusion. You see the permanent molars not so much in scissor bite after 6 months, after the stop of the expansion. The posterior crossbite is self-corrected. I wait few more months, April, so it means 9 more months, and now the permanent molars are touching well. So this is at the top is November, in the middle is July, and down is April. So it took 1 year and a half to notice, to appreciate the self-correction of the permanent molars. I'm not in a hurry. I wait. I take picture and I check the midline and I wait. Of course, after the crossbite is corrected, is self-corrected, I take care of the open bite, and I try and start slicing occlusally the deciduous teeth. But what is important, one more reason why you never will be able to achieve the same perfection in the end result if you use a biomechanic, also sophisticated, on the permanent molars, is what I'm showing to you now. Look at the permanent molars, right and left. At the beginning of treatment, I have a crossbite on the right and normal occlusion on the left. At the end of the expansion, the crossbite is fixed, but I have a scissor bite also on the left. I have a scissor bite on the right. Then in the years and in the 18 months after treatment, you see that the permanent molars spontaneously settle down, and after 18 months, there is a good occlusion in both sides. Look at the lower permanent molar. And now you understand how much you can expect by the occlusal contacts. You understand why you don't need, maybe I had a little bit of luck, I don't know. This is what I was looking for. I wanted to move the lower molar only by the occlusal forces, only by expanding the upper jaw in this patient, and it happened. But this was what I wanted to do before. And if you see, the lower permanent molar now is derotated, is well aligned. Not only the crossbite, overexpanded, self-corrected, and fixed itself in a perfect occlusion took 1.5 years, but also the lower molar fixed. This is magic. This is orthodontics. If you want to do the same with fixed appliances, it's not so easy. Do it, of course. I can do it in many things, in many ways. But in this case, I didn't waste time at the chair. I just did a correct treatment plan, and I saw the patient every 3 months without touching nor the appliance, not even the permanent teeth. So now talk about anterior crossbite. Sometimes anterior crossbite is connected, is evident together with the posterior crossbite. Sometimes there is only anterior crowding and crossbite. This is a very tough case. Believe me, I never touched the permanent teeth. I expanded. This is a screw which expanded 10 millimeters. And as you see, 10 millimeters is too little. I told you before, you need a 13 millimeters sometimes. If you look at the upper right primary canine, you will notice on the right that I had to slice the upper primary canines. It is very rare I had to slice the upper canines, and this is something I never do, but in this case I had to do it. And the reason is not that the slicing is something you must do. The reason is that this screw was not wide enough. This is a screw, I don't tell you the name. This is a screw I was using in the past. It was only 9 millimeter expansion, what I could do. 9 millimeter in this patient was not enough. So I had to do the slicing of the upper deciduous canines. The kids are not happy because the upper deciduous canines, when you need space, are still alive, and it's a little bit painful. you can prevent this necessity of slicing the deciduous canine in the upper jaw by using a 13mm screw. 90% doesn't mean 100%. So in some patient I have to add something. Hey, it's not so difficult to fix a crossbite. You can add an elastic, a wire, whatever you want. But 90% of my patient in 2012, the years before 2012, self-corrected spontaneously. And after 2020, it is the same. They self-correct in the vast majority, 90%. This is a case I treated in 1997. At that time, it was unbelievable to me how effective it is, this procedure. This is December 1997. No posterior crossbite, just a crowding with an extra problem, the crossbite on the lateral incisor. This is the appliance, 1997, same than what I'm using now. The expansion, I didn't touch the permanent teeth at all, nothing. This is the beginning. After 2 weeks, you see the bite is opening because we have pre-contacts on the posterior teeth. You have the palatal cusp of the molars touching on the buccal cusp of the lower molar. And so the bite opens. And if the bite opens, because you have an open bite produced by the posterior prematurity, you don't need to do nothing else than wait. But you need a rapid expansion. So in the presence of a crossbite, I start the first week twice a day, second week maybe again twice a day, if I have no problem of cooperation, no problem of pain in the nose or something like that. And immediately after the self-correction of the crossbite, I want to see it in my patient in 1 month, 2-3 weeks. If it doesn't jump in the first 6 weeks, you have to do something else. And then grinding behind, the bite closes itself, and the occlusion, the lips, the transeptal fibers, they will fix the alignment of the upper incisor. So beginning, opening of the bite, posterior precontacts, and now the crossbite is already fixed, 2 weeks. Now we slow down once a day, once every second day, and just take picture. You don't have to do nothing else than take picture. The bite closes and the lips, transeptal fibers do the rest. Occlusion do the rest. So after 1 year, you see there is no crossbite on the posterior teeth. Once again, you will notice a slicing of the upper left deciduous canine. You don't need to do it if you use a right screw. Also in this case, 90-90-70, the screw is 9 millimeters, too little, too small. It is, you need, in many patients, you need more than 10 millimeters. So I recommend you to use, from the very beginning, a wide screw, because sometimes 10 to 13 millimeters makes the difference. You don't need to open the bite's open itself, and then transeptal fibers, occlusion, closed lips do the rest. Just check the midline. So this is after 1 year, no crossbite before, no crossbite after, fantastic. This is another case, crossbite on the central incisor, no absence of posterior crossbite in the back, a little bit of crowding of the upper incisors, rotation of the upper incisor. They are erupting now. But they are rotated. Rotation of the upper incisor is always a problem in the long term. They never stay. We need to splint it. We need the fiberotomy. So it's a real problem aesthetically talking. But here also you see the crossbite on the upper left central incisor. What do you think I did? You don't need any fantasy. I do always the same. This is a 13 millimeter screw. I open the bite before the eruption of the lateral incisor. The upper left central incisor jumped immediately. 2 weeks, it must jump. 2-3 weeks maximum, the crossbite must be corrected. Here you see now the occlusion will do the rest. We'll fix the scissor bite on the molars. Of course, the deciduous teeth stay where they are. Look at the rotation. I didn't touch the permanent incisor at all. Nothing. Look at the lateral incisor, the upper right lateral incisor. Occlusion is enough. They are not perfect, but this is good. I'm very happy. Sometimes a little bit better, sometimes a little bit less, but this is the rule. What is the take-home message? Try to achieve an early derotation of on the upper incisor, because if the upper incisor self-rotate, correct the rotation during the eruption, they will be more stable during life. This is because, this is a beautiful article, they on the dogs, they extracted the teeth and they reimplanted the teeth, and they developed that the direction of the transeptal fibers is not determined by the anatomy, but is determined by the tooth position during the transeptal fibers development, which means during the last phase of the eruption of the teeth. So it is important to prevent a relapse, and we know that the reason why the rotation always relapses is that we are lengthening the transeptal fibers. The goal of treatment in the young patient is to allow the permanent teeth erupt from the very beginning, already well rotated, in order to allow the transeptal fibers to develop, to consolidate themselves in a proper way, short, at the beginning of the eruption of the teeth in the mouth, immediately after the eruption. So early, once again, the key word is early. Early derotation means if you derotate the teeth immediately after the eruption, during the eruption, they will stay rotated much better. Another case, posterior and anterior crossbite crowding. Don't wait. This is too late. I would have preferred to expand this patient before the eruption of the lateral incisor, but sometimes the parents don't care, and they arrive when the lateral incisor are in the middle of the palate. So the problem is the upper right lateral incisor, the posterior crossbite, the anterior crossbite, the crowding. This is the expansion, 13 millimeters. Now I decided to fix the incisors with some braces. Which incisor do I have to fix? The upper right lateral incisor. The upper right lateral incisor, which was in the palate before, after the expansion, here you see the jumping of the bone. The lateral incisor, the upper lateral incisor on the right, in this stage after the expansion is the only tooth which is perfectly in occlusion. The only tooth which doesn't need any movement is the upper right lateral incisor. If I decided to use two braces only to fix the central incisor and the midline. The central incisor were erupted 1 year before, and if they are already in the arch since 1 year, the self-correction is a little bit less. So the secret, the take-home message is let derotate the teeth, let align the teeth immediately after the eruption, even better during the eruption. So here, the only tooth which is perfectly in occlusion is the upper right lateral incisor, which was before in crossbite. So twice a day, first week, twice a day until you have an open bite and a self-correction of the crossbite. Sometimes in these 2-3 weeks, you also have a post-rotation of the mandible, and there is a tendency of the mandible to shift a little bit back. It can happen. When the kids doesn't know where to touch, you see that the occlusion is very unstable here. So the mandible tend a little bit to go back, and this helps you when you have to correct an anterior crossbite. So now this is a stainless steel wire, very straight. I place the bracket on the canine before in order to see that the wire is perfect. Sometimes one deciduous canine is higher, the other one is a little bit lower, so the braces, the bracket on the canines can be placed in a different way. No? You don't have to look at the anatomy of the deciduous canine. You have to place the slot of the deciduous canine in the way that the wire is very straight. Now, with this guide of the straight wire, we place the incisors bracket, and after a few weeks, of course, not only the midline, but also the rotation of the central incisor is fixed. Always you need a retention. If you fix the central incisor with braces, do a retention, at least for 1 year, minimum. But since they were rotated since many months, they were erupted more than 1 year before, if you don't do a retention, they will relapse. And usually I don't do any fiberotomy at this time. I don't touch the upper left lateral incisor. Of course, I don't want to touch the lateral incisor because inside the roots of the lateral incisor are touching the erupting permanent canines. So this is the end of the expansion phase. Once again, almost 2 years. You see the cubit. I took out the rapid palatal expander in October 2012. But at the beginning of treatment, the pre-treatment records were 2 years before. Don't touch the lateral incisors with braces because you are under a great risk of moving the roots of the lateral incisor against the crown of the permanent canines. And of course, they are not happy. You could create an attrition between the roots of the lateral incisor and the permanent canine. Don't touch the lateral incisor at all. It is possible, of course, but I would advise not to do it until the permanent canines are erupted out of the periodontal tissues. Wait. And if you look at the upper left lateral incisor, it is improving from here, upper left lateral incisor. This is February 2012. October 2012, September 2013. Took 3 years, but now the lateral incisor is well positioned, much better. Wait, don't be in a hurry. Now it's time to remove the splint, because it's not nice to leave this splint. Sometimes there is some movement of the splinted segment. So I leave it 1 year, 1.5 years, then I will fix the position of the incisor perfectly during the second phase of treatment. Now I take advantage of the leeway, the rotation of the permanent molars, slicing of the upper second primary molars in order to gain space for the permanent canines. The permanent canines will push, and when they push, the premolar, the first premolar, goes back. So slicing together with the rotation of the permanent molars. And now the premolar are touching in a very solid class 1. The canines are out. Is not perfect. The lower canine, also the lower right canine, is a little bit rotated. Come on, a short phase 2, September 2015. Remember, the mission of the first phase is to reduce, to minimize, to make the second phase less invasive. Now, it is very easy. It takes few months to fix the occlusion. No? September, February, here is after 1 year. Everything is perfect now. Time to remove the appliances. Fixed retention on the lower front teeth and the S6 retainer in the upper jaw.